Let's now turn to another case where the facial scanner come in handy for correcting a different aspect. The patient had missing developmental buds for the permanent lateral incisors in the upper jaw. On the left, there is a photo from her teenage years. Later, she went under orthodontic treatment in a different clinic where the absence of tooth 1-2 was addressed with a single-sided metal ceramic bridge anchored to the tooth 1-3. The tooth 6-2 was restored with composite. The diastema closure was performed with the composite. And I think that they achieved a mediocre aesthetic effect. Please note the gummy smile present in the lateral section of the upper jaw. Choosing the design of dental work should not be constrained by the bone and gum conditions. The decision-making process should be preliminarily consider aesthetic condition, adapting as closely as it's possible to the expectations. However, one must not overlook factors such as the biological width or the width of the keratinized gingiva. Here we present the DSD that includes the coronal elongation of the lateral teeth, while the central incisors have been preserved. Here we observe a surgical template. Now I use the different type of template with a reversed layout due to absence of need for crossing cuts. The lower photo shows post-operative condition with an earlier prepared mock-up applied. I have changed a little bit surgical technique to apply the mock-up after making incision, but before detaching the mucosa and performing osteotomy. This allows me for better control over biological width and the extent of osteotomy, and also prevents material from seeping under the flap. However, this is a topic for another lecture. Okay, here we see the facial view with the mock-up applied. Please take a look at the design overlaid on facial scan from the front and the profile view. Here we can see the profile view. As I said before, in the work presented, a digital articulator has been utilized. Thanks to RiScan technology, accomplishing this task is possible using standard settings. To replicate individual jaw movement, integration with electronic face bow is essential. Nevertheless, even the absence of such tool working with RiScan ensures higher accuracy than traditional methods without the face bow. We can see the preparation. The tooth 1-3 is preserved as the crown and the bridge, and the tooth 6-2 was also prepared as a crown due to the fact that there is a lot of composite. Okay, please take a look at the treatment outcomes 1.5 years after the completion of the treatment. I like it. This is the outcome. Okay. Moreover, here is the family photo from our vacation in Egypt. She became my wife, and my wife's smile is beautiful and joyful. Here we can see our son Conrad. He smiles as lovely, and I'm proud to share that he still has all his teeth healthy. Recently, our family welcomed our daughter Victoria. For now, she has only 6 teeth. Okay, and here we can see Irena with right face. Okay, so here we can see the simplified protocol for working with the facial scanner. So firstly, we should make preliminary prosthetic treatment plan. Then we should collect the intraoral scan and facial scan. Then we should make the photographs, send it to laboratory, and project DSD, diagnostic workup, and maybe sometimes mock-up. Then we should receive the acceptance by both the dentist and the patients. Then we should decide about the extent of the preparation. We should always remember about the pre-scan before preparation. Then we should make minimally invasive tooth preparation based on the relationship of the design and the patient's own dentition. Then we should make one more scan with the prepared tooth. Then the laboratory should send us the final project and we should accept that. And after all, we should execute the temporary work or the final work. More usually, the final work. Okay, the next case. The subsequent case posed many difficulties for me, not only because of its complexity in terms of implant prosthodontics, but also due to desire to implement the ray phase. Back then, we lacked any protocol or device to merge the intraoral and facial scan for cases with endodontous maxillary alveolar ridge. I believe you might find this intriguing, particularly as it will display the process by which we reached the solution we now employ and still in chasing. Okay, as you can see here in the panoramic images, the patient suffered from extensive atrophy of maxillary alveolar process. For this reason, I could not opt for traditional implantological procedures. Such atrophies are not suitable for therapy through bone regenerations. Hence the decision to use the zygomatic implants. Working with zygomatic implants presented many challenges due to the fact that their apexes are usually positioned palatally in relation to the maxillary process, and the multi-unit are located deep within the soft tissues. Furthermore, due to their length and the distance from the anchorage point, zygomatic implants exhibit slight flexibility, which can cause the breakage of the rigid work. Okay. Here we see how at that time we were transforming the position of the processes to the facial scan. It was relatively effective. On the wax pattern, we would attach the plastic beds of a known size to the technicians, which we adhere to the wax pattern. Then we send the facial scan along with the pattern to the intraoral scans to the laboratory. Later, we modified the method as follows. We used the applicator to create the grooves on the pattern into which we inserted the lines made of twisted Teflon, forming the rectangular grid. This was a better method due to greater number of visible points to the facial scanner and lack of Teflon displacement during the transfer. Okay. Here you can see the intraoral scans. As you can observe, I decided to preserve the teeth in the anterior sections of the mandible. Despite the absence of the one incisor, I considered that despite some asymmetry, it is worth to using them for the future work due to the preservation of the sense of the occlusal height and muscular tension through the periodontal ligaments. Having a spatial positioning of the models, we conducted a diagnostic waxing which showed to the patient. Ultimately, the design was modified due to the teeth being set too narrowly, causing the impression of the black tunnels in the lateral part of the smile. Here you can see these tunnels. It was our fault. Here you can see the project overlaid on the facial scan. Here you can see the printed denture, which we showed to the patient at that time. In this images, you can see the methodology of taking the digital scan that I use. In my opinion, to collect the accurate data in a dental processes, neither any expensive devices like the PIC camera, nor appliances like smart flag scan bodies are needed. Just a treat and resign like a Structor or Luxatemp or something like that. We perform one scan without the treat and the second one with the scan bodies screwed to the multi-unit, and the third one with the treat. Anyone involved to analog implantology has probably noticed the similarity to the commonly used method.